Thanks everybody for joining us today. We're joined by Dr. Matt Bush from Kentucky. He attended med school at the Marshall University Jones C. Edwards School of Medicine in West Virginia, and then completed an otolaryngology residency at the University of Kentucky. This was followed by a postdoctoral research fellowship and clinical fellowship in neurotology at the Ohio State University. And then he subsequently completed a PhD in clinical and translational science in 2017, as well as an MBA in 2020, both from the University of Kentucky. He's now the chair of the Department of Otolaryngology and conducts research focusing on hearing health disparities. So thank you for joining us today.
Thanks so much, Steve. It's a pleasure to be with you. Good morning, everyone. I'm going to talk to you today about prioritizing hearing health equity, the power of pragmatic research. This has been an area that has been personal and important to me, just based on where I practice geographically, but also just scientifically, considering the complexities and the opportunities that we have as a field of otolaryngology to address health equity. These are my disclosures. I'm a consultant for the cochlear implant companies in different ways, but there's no conflicted content with what I'll discuss today. And my research is supported through the NIH, primarily the NIDCD, through various funding mechanisms. I do want to send you a warm greetings from Kentucky. It's rather rainy here this morning, but Kentucky is a wonderful place. It's been a beautiful place to train, to practice, as well as to raise a family and live. It is home to some pretty rabid, crazy basketball fans. So it is a bit of a religion in the state of Kentucky, Kentucky basketball. We have a different coach now. Coach Calipari is over in Arkansas. Mark Pope's our new basketball coach. So everyone's waiting with bated breath to see what happens. We also have a pretty fantastic women's volleyball team that does pretty well on the national scene, as well as within the SEC each year. Certainly historic and culturally, President number 16, Abraham Lincoln, was born in Kentucky and lived much of his youth and teen years here in the state of Kentucky. And also, of course, Kentucky is pretty infamous for KFC, the birthplace of heart disease and some heartburn and some trans fat fried chicken. Believe it or not, though, Colonel Sanders is not from Kentucky. Just like I'm not from Kentucky originally, he's actually from Indiana, but made his chicken empire out of Corbin, Kentucky. You can actually go to the original KFC, which was sort of a roadside hotel, restaurant, service station originally, and you can get the Colonel's fried chicken there. But believe it or not, the chicken tastes the same there as it does anywhere else on the planet. So, and also, of course, Kentucky is known for horse racing. Has two of the most famous horses in modern history, Justify and American Pharoah. Were raised and trained and have gone to pasture here in Kentucky. Both of these horses are not very far from even where I sit right here in Lexington. And one of the sacred spirits, bourbon, it finds its birthplace here in Kentucky, and 98% of the world's bourbon is made within about an hour and a half radius of where I am right now. So this particular picture is the Holy Grail, the Pappy Van Winkle, or the Van Winkle series of bourbons that are pretty ridiculous price-wise. So I promise not to bore you more with Kentucky history or culture, but I will talk to you a little bit about some things related to health equity, and we will get back and discuss some things here in Kentucky related to that, but it will be applicable to all of us wherever we find our practice. Our objectives today are to talk about some of the challenges and complexities of inequities in otolaryngology, and specifically hearing healthcare. We'll also evaluate some research methods that can be used to address inequities through community engagement as well as community involvement. We'll also talk about some examples of some pragmatic clinical trials that I'm involved in currently that can be used to promote equity in otolaryngology. As we get started, I want to tell you the tale of two 4-year-olds. And these 4-year-olds are real and have been a part of my practice at different phases. And this particular one I saw when I was, this is a patient of mine from my practice now, but this is a 4-year-old female who's from the Lexington area, which is a suburban area, born healthy at birth, was referred in both ears for on her newborn hearing screen. She followed up in a timely manner and had diagnostic audiologic testing and found to have profound hearing loss on the ABR. She quickly got connected to hearing healthcare with amplification as well as speech therapy services. And was on track to move towards implantation. At 6 months of age, without evidence of speech progress, had a repeat ABR at the same time of her sedated MRI, reconfirming the diagnosis of profound sensorineural hearing loss. She underwent bilateral cochlear implantation at 9 months of age, and she has been consistent with speech therapy and audiology appointments, even during the COVID pandemic through some telehealth connections. And this 4-year-old's got robust speech development. She's headed to K5 next year. This is a high five patient, that we just love to see, and reasons that we just sort of fill the depths of our heart with a lot of joy and happiness to be able to be involved in her care. This next 4-year-old is a little bit of a different story. This is a 4-year-old male that I saw here when I was a resident here at the University of Kentucky. And this 4-year-old presented from a very rural Kentucky community. He was born healthy at birth, but referred on both of his ears on his newborn hearing screen. Notice that he didn't come into any hearing healthcare center until 3 months of age. So there was a series of missteps and miscommunications. And so the diagnostic test, when he did show up to the audiology clinic, which was a public funded health center, was canceled due to transportation problems. And the challenges continued from 3 months into 4 years of age, with ongoing scheduling problems. There were no local hearing healthcare providers, no otolaryngologists. And even in the county where he lives, there's not a single healthcare facility or healthcare provider of any type, not an urgent treatment center, not a pharmacy, not really any source of healthcare in his county. And this child, as he had been seen by a pediatrician or some type of primary care provider, had been labeled lots of things, autistic, and different types of other labels that kids with hearing loss have. He showed up at our doorstep at 4 years of age, had diagnostic testing, and again showed, profound sensorineural hearing loss similar to our first 4-year-old. So seeing a child like this, in, our country and a setting where we would say that we're a pretty well developed, well resourced, strong infrastructure type country, is pretty impactful. Seeing a child like this impacted me as a human being. It impacted me as a parent. It impacted me as a otolaryngologist, and impacted me as a scientist. And so, of course, this child has had no treatment of any type, no speech development, has really been locked in and unable to communicate. So considering these types of, differences in care, I ask you a challenging question, which I don't have the answer to, but for every patient, how can we get them what they need when they need it? And these underlying yellow words are essential, that every patient could get what they need and exactly when they need it, because timing is of essence in a lot of areas of healthcare, especially in hearing health. The problem that we face in otolaryngology is that these health inequities are pervasive and persistent. These inequities are rooted in real world problems, and they thrive in very complex scenarios. And so this requires a pretty drastic approach to try to deal with this. Why does this matter? Well, there's very clear evidence and direction, of where healthcare is going, and that patient-centered care is not only, the wave and the direction in the future, it is here now, and that patient-centered care is at the center of reimbursement, policies, of programs, and how we're going to be able to deliver care. And patient-centered care is all about having kind of a holistic view of a patient's health, their circumstances, and well-being. Basically looking at a patient beyond just their cochlea or beyond just their audiogram, and understanding that there's a whole lot more to that patient than just their hearing, that may need support and help and guidance to help them to reach optimal health. This particular monograph, produced by the Robert Wood Johnson Foundation, had outlined some areas in which we're failing to deliver patient-centered care overall in general in the U.S. And these challenges relate to inadequate information for a lot of patients that lack literacy in health and health care. There's inadequate trust across a wide range of different cultures and ethnic and sociodemographic factors. There's organizational cultural and clinician training and belief challenges in how we understand patients and how we listen to patients, how we give them our time, and how our organizations support the delivery of equitable care. There's also a misalignment of incentives and expectations for the healthcare workforce. So how do we advance health equity? Also a challenging question, and this particular monograph from the American Public Health Association doesn't give us the answer, but outlines some, I think, really helpful things that I think should be useful for us in the context of what I'll talk about during this hour. But one of the important things for us to advance health equity is that we need to be explicit in that we need to define disparities for what they are. We need to describe them and we need to publish on them. We need to make it very clear the differences in health, differences in healthcare outcomes, differences in access, utilization, across a wide range of different factors, whether that would be socioeconomic or racial or ethnic or gender or geography, whatever it might be, we need to be able to describe this. Because if it's not described, if it's not published, then that's only really just viewed as an assumption, or perhaps in some negative light, it might be a stereotype. But we need to be honest about, how health is in the world today, and that's what research should help us do. Furthermore, we can't just publish and define the disparity. We've got to take a deep dive and understand the causes, the mechanisms of how these disparities and inequities, came to be and why they are so persistent. We need to create a culture of equity. If we believe on trying to promote equity, then we need to be equitable in how we take care of our team, our partners, our learners, our patients. It needs to be something that we believe in, that, in a fundamental way, in an altruistic and humanitarian way of promoting equity in all of our dealings. We need to respect and involve our communities. We don't just go to communities and just get data from them, but we need to respect them, listen to them, involve them, and work together to solve these problems. And then we also need to measure and evaluate our progress to see if we're failing or if we're succeeding in reaching our goals to address inequities. The causes of inequities are challenging. The social determinants of health have been applied. And interestingly, we've done a poor job in otolaryngology in general, fully describing all the different non-biological factors that can influence health and healthcare outcomes: education, social community context, economic stability, neighborhood and built environment, healthcare access and quality are these 5 different domains that are areas in which these different factors of having good quality healthcare. Example, I talked about the 4-year-old that doesn't have any kind of a provider in their county. That's a healthcare access issue. But there's other things that relate to it as well. What about some of the social and community context, or how are our neighborhoods or our physical environments built for health? For example, are there parks near where people live so that they can get physical exercise and live healthier lives? But in hearing healthcare, we've published a little bit on healthcare access and quality, maybe education access and quality, maybe a little bit in economic stability. But we really haven't done a lot of research in hearing healthcare in social and community context or neighborhood and built environments. So there's a lot of work to be done to dive deeper into these causes for inequities. So what I'm going to do now is I just want to talk to you a little bit about some relevant hearing healthcare disparities, inequities. And I'll start first just describing, based on some of the research that I've done as an example, because there's certainly these inequities are present in so many different demographics in urban areas. This is not something that's unique to rural areas, but this is something that at least my research can give you some examples of how we can at least define and describe some of these inequities. Just to give you a little bit of backdrop furthermore, on a health and social perspective about the region in which I practice, I practice right where the yellow star is on the map, which is in Lexington, which is actually not in Appalachia. The Appalachian counties are shown here on this map, and you can see it's a pretty broad geographic area. It's actually 8% of the U.S. population that live in Appalachia, but it stretches from New York all the way down to Mississippi. And on this heat map, you can see, socioeconomic depression. And this eastern third of the state of Kentucky is some of the most socioeconomically depressed counties in the U.S., this Appalachian region of Kentucky. The majority of Kentucky is rural in nature. The Louisville and Lexington are the larger cities. Covington, which is just south of Cincinnati, across the Ohio River border on the Kentucky side, is another, suburban, small urban area. But it's a largely rural state. This region of Appalachia has been known as the opioid epidemic epicenter. I mean, there's thousands of deaths occur every year due to opioid overdose and abuse. It's an area that has been facing persistent poverty. This is a title that you do not want for your county. So a county can be labeled as persistently impoverished, and basically that's defined as 40% of your population below the poverty line for 40 consecutive years. I mean, that is generational poverty, and that really impacts, education, life expectancy, as you see here. Of course, another backdrop in this area is a pervasive high burden of chronic diseases with premature deaths due to heart disease, diabetes, and cancer. So it's in this backdrop that, I as a resident and then, as a junior faculty, as I returned to the University of Kentucky as a faculty member, began to think about, like, we serve this population and we've, what are we doing to define and describe in the hearing world, the inequities that exist for this population. We started by partnering with our early hearing detection intervention agency through the Cabinet of Health and Family Services here in Kentucky. And they've been great partners and enabled us to really look at a population level and understand differences in urban and rural pediatric hearing health care. So we've published in the Journal of Pediatrics a number of years ago about poor follow-up after a failed newborn hearing screen. Rural infants have a significantly higher no-show rate after a referred screen than do urban infants. And then if you look at those children that when they're, what's the difference in the timing of diagnosis after birth, that rural infants in this cohort were diagnosed at about 7 months of age, whereas urban infants were diagnosed about 5 months of age. Of course, our goal, according to Eddie, would be as soon as possible, but no later than 3 months, according to the 136 guidelines. We've done some other research and used some methods working with epidemiologists to try to understand, are there any geographic regions that have a significantly higher incidence of hearing loss using a spatial scan statistic. This particular study looks at some of the birthing centers that have some higher incidence of hearing loss, but then it clusters geographic regions where there is higher incidence in multiple contiguous counties. So we might expect where the blue stars are, where some of our larger medical centers are, UK the UK Medical Center, University of Louisville's Medical Center here, kind of the center blue stars. But, those are some sicker patients, some complicated pregnancies. So we may have higher incidence of hearing loss there, but none of the other parts of the state really had higher incidence of hearing loss except the westernmost part of the state. This is called the Jackson Purchase area. And this is a very rural, farming is a major part of life in this Midwestern part of the state, and limited access to care. Patients either go to St. Louis if they're able to, if they have private insurance, or they may come to Lexington or Louisville, or may go to Nashville for care. But 7 out of 1,000 live births was the incidence of hearing loss there. We don't really know the mechanisms, the reasons for this, whether this is genetic or it's environmental or what the deal is. But this kind of research is necessary because we've got an area that doesn't have any cochlear implant centers and has one otolaryngologist that's in the area and one audiologist that's in that whole region. So it's a huge area of need, at least geographically. Furthermore, thinking
Hey,
about,
Matt.
Yes.
Yeah, Bill Slattery, if I may just interject. I went to University of Missouri Medical School, and Southeast Missouri down in Cape Girardeau, which is right across the Mississippi River from what you're talking about, had the highest incidence of genetic deformities. The University of Missouri had big genetic programs looking into that area as well. So I do think there's probably those areas are very close. There's probably some sort of a genetic preponderance in that area.
Yeah, you're probably right. Thanks for bringing that up, Bill. And I use this as an example, not as like, okay, the whole field of otolaryngology, like figure out what's happening in the Jackson Purchase, but the research methodologies that are used here is what I think is translatable and meaningful. But you've got to keep asking questions and keep trying to dig deeper. And if we've already got a population that has this higher incidence of hearing loss and then a mismatch of services, I mean, we've got a real neurocognitive crisis, if you will, to try to address these disparities. So thanks for bringing that up. So looking, onward in this continuum of hearing healthcare for children, we've done some research that defines the timing of implantation of children based on, hearing loss at birth and when do they actually get their implant. And this study looks at, this group of urban children versus rural children. And on average, rural children take 2 times longer to get hearing aids and 2 times longer to get their cochlear implant. And using this Kaplan-Meier analysis here, you can see this was kind of that 4-year-old child that I saw when I was a resident. This is the aha moment that like validates that, yes, this child is not just a one-off, but this is a thing. This is real. We've got 5-year-old kids that are getting a cochlear implant when they should have got it at 9 months or 1 year or much, much earlier than this. So it's really a concerning factor of this delays in care. What happens after rural children get their cochlear implants? Well, we've evaluated a cohort of cochlear implant recipients and looked at the differences between rural residents and urban residents and some of their access and outcomes. And those that live in the rural areas have a longer distance to audiologists and speech language pathologists. I know that's no surprise there, but they also had a much lower likelihood of gaining access to a speech therapist before they had a cochlear implant, which is really shocking that they needed a speech therapist, from day one that, hearing loss was being discussed. They also have had a higher likelihood of device problems. And that's an issue because if their device is not working and they don't have meaningful connection to the specialist, they'll be less likely to use the device at all. Furthermore, in this study, we've looked at the parental education level, and that was linked to poor outcomes for children overall, regardless of where they live. I'm going to shift gears a little bit and not talk about cochlear implantation or sensorineural hearing loss, but look at some chronic ear disease as it relates to urban and rural and some of the insurance coverage. Many of our rural residents, of course, would have Medicaid insurance. There's some with private insurance, but the overwhelming majority have Medicaid. And we've looked at a cohort of patients who've had chronic ear disease that have had tympanoplasty or tympanomastoid, and looked at some of the differences in their utilization of care. Children that had Medicaid had significantly higher odds of preoperative no-shows for clinician appointments with their surgeon, and higher odds of no-show postoperative visits, and a significantly lower, 59% lower odds of having a postoperative audiogram. And this is really problematic because, if we haven't closed that airborne gap and the child has persistent, mild or moderate hearing loss after chronic ear surgery, we need to document that. We need to amplify that. We need to address that. So we've got kids that may get care, but if they get care with surgery to manage their chronic ear disease, they're not getting the supportive postoperative audiograms. Interestingly, too, there's a significantly higher rate of cholesteatoma in Appalachian children compared to those that did not live in the Appalachian area. Likely those retraction pockets that just persisted and weren't addressed until it was full-blown cholesteatoma. We're also learning lessons from our pediatric audiology clinic. We've looked at 2 years worth of data to evaluate no-shows, and what are the factors that might influence no-shows in our academic practice. Overall, we have a 24% no-show rate in this study period. Younger children in this study had a higher no-show rate. In this particular study, we did see a relationship with race, and the African American population participants had a 40% higher no-show rate. As I discussed in the previous slide, Medicaid had a higher no-show rate. The audiogram was the audiologic appointment type that was the highest no-show type. And then in Kentucky, at least in this study, summer was the highest no-show season. Some of these communities that are involved in farming or more, activities in the summertime might have contributed to higher no-show rates for this population. Again, I think the methodology is important to try to understand from these different perspectives, all these resources and all these challenges, and who's at the highest risk, who is our more vulnerable populations. This is another slide I want to talk to you about coming up about race, ethnicity, and pediatric hearing healthcare, because it's important. And there is a rising tide, thankfully, that's documenting and describing racial and ethnic disparities. This is not research of mine, but research from a good friend of mine, Cedric Pritchett, at Nemours Children's Hospital in Orlando. But they looked at 12 years worth of research, 12 years worth of data, pediatric cochlear implant in Florida, and found that no Black child was implanted younger than 12 months of age, where there were other white children who had. Furthermore, if you just looked at the age of getting an implant by 2, there's a lower likelihood of Black race, Hispanic ethnicity, and those with Medicaid insurance to get a cochlear implant by age 2, compared with white children or privately insured or non-Hispanic. Furthermore, white Medicaid self-pay patients were still more likely to get a cochlear implant by age 2 than Black children, even if they had private insurance. So, Cedric's study here very clearly articulates some ongoing, racial and ethnic bias and, significant disparities that need to be addressed. Now we'll shift gears even a little bit more and talk about adult hearing healthcare. I really like this diagram that's in a paper by Ashley Nassiri and Matt Carlson that describes this long and winding road of the journey to hearing healthcare, from self-identifying that I think I've got a problem, which may never happen. Actually, it may just be a PCP that might involve a patient. So people enter in the hearing healthcare road in different ways, but through hearing aids and possibly cochlear implants if indicated, and all the care that's necessary. So it does beg a question, would you seek hearing healthcare if you had to do all of these things? seems, could be hard enough to just see a primary care doctor, as a clinician, or see your dentist consistently because of the busyness of practice and life. So I think these two areas are really ripe for discussion and further research. These are the entry points, or potentially the exit points, into hearing healthcare, where someone is outside of hearing healthcare and then enters into some kind of discussion or evaluation with their PCP, and maybe a referral to an audiologist. So being from the outside, getting to a diagnosis. Furthermore, this other area, this red circle to the right, is a transition phase from hearing aid to cochlear implant. So we often have these leaky pipes in hearing healthcare where patients are often lost and just never get through to the next stage. So these are important areas for research, and I'm going to talk about these a little bit. I've got the same map up here about the Appalachian area. As we think about adults with hearing loss, it's important to consider these social determinants of health in this population. Overall, and just in general with adults, we've got 40% of older adults that have hearing loss. We've got low utilization of hearing healthcare in general. Only 26% of adults have had an audiogram in the last 5 years. And we ask ourselves, this is, the kind of research I'm doing now, is thinking about, okay, what about the more vulnerable populations, like those rural adults that have longer commutes, lower education, maybe unfavorable insurance, maybe their socioeconomic status is lower, and the incidence of hearing loss very likely can be higher in these rural populations as well. So based on this research grant that we have from the NIDCD, it's a phased innovation grant. The R21 part is what I'm going to talk to you about next. This is basically where we partnered with rural health clinics throughout Kentucky, and we are evaluating patients and providers. The patients were being evaluated for barriers and challenges for hearing healthcare and their perspectives, but then also ask them some key questions about whether you'd had an audiogram in the last year or the last 5 years. And then we conducted a hearing screen in the rural health clinic while they were there with their provider. We've also evaluated some of the providers' perspectives about, the challenges they face in discussing, addressing hearing, and how to get patients to a diagnosis. So this slide here describes some of the quantitative data in which, demonstrates low hearing healthcare utilization and high hearing loss prevalence in a sample of 388 patients with an average age of 51 that were recruited from these 10 different sites across Kentucky. You can see that, the prevalence of having an audiogram within the last year was only 3.4%. Within the last 5 years, it was only 13%. So lower than national averages. And when we do a hearing screen that was done through an HHI and a MIMI hearing screen using an iPad and a quiet environment, 70% of these participants had hearing loss, 30% in the normal range. So again, higher incidence of hearing loss, low utilization for hearing healthcare. Looking at some other factors in this population as well, that, the likelihood of having hearing loss was higher in those with less education. And then also those with hearing loss also had a significantly higher incidence of mental health difficulties, either with anxiety or depression. That's not novel to the hearing healthcare community, but certainly in this population, it represents it, because also behavioral health services and support and mental health services are little to none in these communities. So how does this impact, these low utilization of hearing healthcare? How does it, impact the treatment? Well, these are a couple of studies that we've published that define the timing to hearing aid amplification for urban versus rural and cochlear implantation. You can see it takes significantly longer period of time, 29 years versus 19 years, for rural adults to get a hearing aid from the point of identification of, I think I have a problem. Similarly, there's this long journey, 36 years for rural adults getting a cochlear implant compared to about 29 years for those in urban areas. And, those in the rural communities even said that, hearing loss had caused them to lose a job, those that got cochlear implants, and they were discriminated against in the workplace because of their hearing and inability to find employment. Other states, other researchers have demonstrated how other socioeconomic factors and demographic factors are influencing cochlear implant care. Some research here that's described from Texas and from South Carolina, demonstrating, and Georgia to describe some of these challenges. There's a lower likelihood of pursuing a cochlear implant for those non-white patients, those of older age, those that are single or widowed. Furthermore, there's delayed implantation based on non-white race. And then, of course, insurance with Medicaid continues to be a barrier for all forms of cochlear implant care. These are a couple papers that we've described some of these social determinants of health and some of the literature in each of these relative domains, and some opportunities for more work to be done. So what do we do about it? I'm sorry to give you so much depressing information, so I don't want to leave you with this. I want to give you some hope and maybe some guidance on what we could do to pursue equity in hearing healthcare. Well, first thing I think it's important to do is that we need to promote equitable research and reporting in our research studies. So there's some evidence that we're really not doing a great job of recruiting equitably and reporting who we're doing research on in an equitable manner. So Carrie Neiman and her group described a systematic review that they did in which demonstrated in hearing loss related research that recruitment is overall inequitable. It doesn't reflect the gender makeup of our larger population, and the racial and ethnic makeup of our population does not match with who is recruited and who's involved in research and hearing related prospective trials. Primarily, it's white, privately insured patients who are a part of a lot of the clinical trials, frankly. We conducted a systematic review. Garrick Meinhardt's the first author of our paper that described what was just the reporting. You did a prospective trial on a cochlear implant of a variety of different types, but did you report sociodemographic of your research participants? And the hypothesis is that we're not doing a good job, and our research supports that hypothesis. Less than 10% of cochlear implant trials report key sociodemographic factors. That would be race, ethnicity, socioeconomic status, education, insurance, geographic residence, rural, urban, or a socioeconomically depressed region that they live in. So that's improved slightly overall in gender. That's about 10% that's been reported over time, but majority of these areas are unreported in cochlear implant research. We need to promote accessible information for patients. Some research that we've conducted looking at the readability of website printed written information about cochlear implants demonstrates that cochlear implant website, whether it would be an industry supported website, a cochlear implants website, or a company's website, or if it's a private academic, patient support group, overall readability is poor. It should be on about a 5th to 6th grade reading level, and all of these websites, over 80 websites, the average reading level was a 10th to 12th grade reading level. Furthermore, the quality of this information, using a standardized criteria to evaluate this on our research team, that the quality of this and consistency of this information is poor. Now, I realize that patients learn about cochlear implants in lots of different ways. It might be TikTok, it might be Instagram, it might be through videos and through word of mouth. And there's many other ways that patients can learn about cochlear implants, but we can fix this. We can make our information more readable. And the way that we make it more readable is that we use smaller words that have less syllables, and we use shorter sentences. It just makes it more digestible and more understandable. The exact same thing is found in the hearing aid literature. So we've published on this as well. This paper is in press now with JAAA, but Again, reading level of hearing aid, website, information, 10th to 12th grade reading level, and overall the quality of the information is poor. So we can get better information out there. We can do better recruiting. We also can do better research. We can also use some research methods and designs that could really help us address equity. This is probably one of the more important slides of the whole presentation, because this is just some practical methods in which we do some of this equity research. We use mixed methods. Mixed method means we use some qualitative research and we use quantitative research. Now, I'm going to ask you, when's the last time that you read a qualitative research paper in the White Journal or in otology, neurotology, or laryngoscope? It's not in the mainstream of otolaryngology literature, but this type of research is critical for health equity work. We also want to evaluate these social determinants of health data and sociodemographic data of our participants in every research study that we do. We need to know who we're studying. We need to know the factors that are influencing their health. We also want to be engaging with the community and work with communities closely and partner with them. Clinical trials are also essential, whether that be a medical, device or medication, or behavioral interventions that we're working to try to promote changes in how they access care. It's critical to address equity. And then also incorporate dissemination implementation science, which I'll talk more about in just a moment. So again, I talked about qualitative research. You don't have to do this exclusively, but what it does is it strengthens quantitative RCTs and the research that we do. How it does this by helping to address the appropriateness, the acceptability, and the feasibility of maybe an intervention that we're testing, or a type of programming strategy for a cochlear implant, for example. There might be a wide range of things that we learn about it. Qualitative research also helps us to inform how should we develop a questionnaire, or maybe how should we recruit other participants into our research into this field. And lastly, qualitative research helps us to understand mechanisms. Maybe quantitatively, we didn't get the p-value or the confidence interval that we wanted, but qualitative research can tell us from patients directly and participants directly why this didn't work or why it did work. There's a wide range of ways in which we can also collect social determinants of health. This is a couple screening tools or inventories that can be used, one through the National Association of Community Health Centers, as well as the American Academy of Family Physicians. Easy ways for us to evaluate some of these core factors that are in those 5 different domains, social determinants of health. Community Advisory Board is essential for health equity research. There is true strength and diversity here. And working with a group of stakeholders and individuals to be involved with our research is important to establish communication and build trust in the community that we might want to do research in or with, to develop a common vision of priorities and protocols and how the research is going to be conducted. We might get amazing, innovative ideas from the community members, and we can celebrate these successes together. And then if our research is successful, we want to get it back into practice and in the community. And this is where community advisory boards make this eminently more possible. So my impassioned plea would be that every research lab, even if you join bench research, you should develop a community advisory board, because if it has anything to do with human beings, we need human beings that are outside of the science per se, to be a part of learning and communicating and processing what it is and where it could go. Clinical trials are essential. We don't just do retrospective research. We don't just do systematic reviews for health equity. We've got to be proactive and do prospective research. And not one size fits all. We can use an RCT, which is sort of a historical gold standard in biomedical research, and randomize individuals. But we can also use a cluster randomized trial in which we randomize perhaps different communities or different groups of people to connect, to receive the intervention or receive a control condition. And we could also use a step wedge design, which is sort of a waitlist control, where maybe a number of clinics are going to get the intervention eventually, but everyone's in the control condition until the intervention is launched, and that might happen on a 6-month delay. And so there's steps in which a new clinic is added and then starts to receive the intervention. So there's lots of different ways. It should be based on the community's perspectives and input on what's being done and what type of design that they want to be a part of, and also what's best scientifically for the research question. This particular paper describes the pros and the cons, the limitations of each of these three clinical trial methods in equity research. D&I science is a growing field. Implementation science is the process of putting to use or integrate evidence-based interventions within a specific setting. Dissemination is about spreading evidence-based interventions to a broader audience. And so why do we get involved in D&I science? It's because messy real-world problems require a pragmatic attitude that help us find solutions and active collaboration. And you can do this work exclusively, the process of it, changing an intervention so that it's more useful, let's say, from the hearing clinic, maybe to a primary care clinic, or to a private practice clinic to an academic practice. So there's a wide range of different types of research, but often we integrate this in with these pragmatic trials that we do. Most of the research that we do our fields involve the bottom left corner, pre-intervention pilot studies, maybe an efficacy study and a randomized controlled trial. Maybe we'll do an effectiveness study across a wide range of different recruitment sites, but often we stop there and we don't consider these other factors of the new settings that maybe this needs to go to. Make the intervention need to be adapted? Or what does it take for adoption of a new site or a new place to take on this intervention? How do we implement that into the practice? And how do we scale up and make it sustainable? D&I science is all about that stuff in the box, about how do we figure out, getting research interventions to a broader population. Let me give you, as I close here, just some examples of pragmatic research based on some real problems and challenges that we face. So I've developed a patient navigation program related to pediatric hearing loss here. This was a part of my K Award a few years ago, as well as some of my PhD dissertation was about this. Patient navigators come from the cancer world, in which trained lay healthcare workers can provide some educational, psychosocial, logistical patient support to help patients be adherent to obtain some challenging care. Looking at the cancer literature, I've published a systematic review that describes that patient navigation actually really supports healthcare utilization. And even those that come from marginalized, challenging scenarios, they're more adherent to get their chemotherapy or to get their radiation or surgical care in the cancer world if they use a navigation program. And so we developed a patient navigation program for those infants that failed or referred on a newborn hearing screen to get diagnostic testing. And often these navigators intervene and interact with patients over phone or by text to promote them coming in and reinforce the 136 guidelines. Screen by 1 month, diagnose hearing loss by 6 months, and get access to care, treatment no later than 6 months. And this was my trio thesis that described basically a small efficacy study in which we used the patient navigation in an RCT design. And we found that those patients that received the patient navigation intervention, the follow-up compared to the control condition went from 68% up to 93%. So 93% of these families came back for diagnostic testing. And the timing of diagnosis actually went from 106 days down to 68 days. Some of the mechanisms that the patient navigation may have improved the parental knowledge of these 136 guidelines. But, this is a high five moment. This is great. However, this is a small study in one site in one place. So what about the whole state of Kentucky? The University of Kentucky can't be everywhere at all times. So this is where we want to go beyond just an efficacy study and do a broader effectiveness study throughout the whole state using a different health system, which is our publicly funded system in which children can get diagnostic audiologic care in some rural and remote areas. And so this is a current R01 in which we're doing this effectiveness study of the navigation, and we're also evaluating some implementation factors that may influence its success or its failure, and doing a cost analysis of what does it cost to use a navigator, and does it prevent no-shows and improve the overall financial health of this publicly funded health system. So, this type of work is fundable by the NIH and the NIDCD, and it's actually a priority area within the NIDCD to promote hearing healthcare access. And that's what this research, the BMGA Open, describes the protocol that's used in this study. I alluded to this before when I was talking about the adult hearing testing and prevalence of hearing loss. This study, in which we're working with rural health clinics, again, helped us to kind of evaluate some of the factors, and in this exploratory phase, using some mixed methods, we evaluated the hearing utilization resources, did a hearing screen. We're now in the R33. This is the intervention phase, in which we're actually adapting our pediatric patient navigation program to the adults to be able to use a community-based patient navigator that will help patients get from the rural health clinic to an audiologist to get diagnostic hearing testing. So this work is ongoing. It's not complete yet, but this is just the type of work that can be done pragmatically using different clinic sites, new health systems, to be able to improve access to hearing healthcare. And lastly, I'll describe this study. This is a study in which Susan Emmett at the University of Arkansas and I are co-PIs. And this is about trying to reach out to these rural areas where there's no hearing healthcare provider or any healthcare provider of any type, and use telemedicine through the schools to be able to reach these children and provide better hearing screening. The school represents a very critical healthcare delivery site for many of these rural communities. And so every single county has a school, even if they don't have a healthcare provider. So the role of this research is adapting work of using telemedicine to do hearing screening that Susan has done in Alaska, rural Alaska, and adapt this to the lower 48 states and specifically rural areas. And simultaneously, we're going to evaluate an effectiveness of whether this improves the number of children that are screened, children that are referred, and the children actually follow up to a hearing healthcare location, which is shown in the black stars. There's some specialty hearing healthcare clinics where they can go for free, but do they actually show up there if they get better care and better resources? So I want to leave you with a call to action for equity. Even though it's a bit overwhelming and somewhat daunting, don't be, paralyzed with inactivity and confusion. Be active to define inequities. And they're evidenced across a wide range of sociodemographics and influenced by the social determinants of health. But be a part of this, of defining that these problems are real. Publishing on this can be, an academic programmatic line of research that can be productive. But also, I encourage you to consider, conducting equitable research and how you recruit, how you report, and what you report about the participants that you're conducting research on. And we also need to incorporate some of these novel models and methods, study designs to promote equitable care and efficient translation of research to broader practice and populations. Okay, thanks for putting up with me droning on there for an hour. But again, I'm welcome any questions and thankful to be here with you all.